Hello, my name is Jos van den Berg, and today I will discuss with you and with two great experts the main highlights from the IN.PACT Global Real World Data. And the two experts are Gunnar Tepe from Rosenheim and Thomas Zeller from Bad Krozingen, both from Germany, and both have been very involved in all the trials with drug-eluting balloons. And Gunnar Tepe has been also the principal investigator in the European part of the IN.PACT SFA trial and has been part of the steering committee of the IN.PACT Global study, while Thomas Zeller was one of the high enrollers in both of the studies. So we will have two experts that will answer the questions that I've prepared. And I will start first with Professor Tepe. Gunnar, from the IN.PACT SFA trial, we have learned a lot of things. But can you tell us what has differentiated the population that was enrolled in the IN.PACT Global study from the pivotal trial? And as we know, both of these studies have demonstrated the benefit at 5 years.
Yes, thank you very much for this great question. Yeah, the IN.PACT SFA trial was a great study comparing the drug-coated balloons with a POBA, but nevertheless there were a lot of exclusion criteria which had to be made. So if we really want to look into the real world, we have to look into the 5-year data of IN.PACT DCB. So also long lesions could be included here, which was not allowed in the control trial, instant restenosis and very calcified lesions. So almost all patients could be included here. So if we really want to learn how this IN.PACT DCB works in the real world, only this data can be taken here.
Can you tell us a little bit about the design of the study? What were the specific lesions that were looked at?
Yeah, that was a really big study, a study which almost 1,500 patients, and there had been 3 groups which were predefined before: instant stenosis, long lesions. Those lesions were also followed with ultrasound. With this, the patients were followed in a very good manner. So we had the clinical follow-up for 5 years, as well as ultrasound follow-up for a certain time of those pre-specified patients.
When I look at the data that came out of the IN.PACT Global study, and I compared it to the data that we have seen from the IN.PACT SFA, you would expect, given the fact that there were a lot of difficult lesions included in the IN.PACT Global study, long lesions, CTO, instant restenosis, but actually the outcomes are very consistent. You see more or less the same patency rate. How can you explain this consistent outcome from a very select population like the IN.PACT SFA on one side, and then the IN.PACT Global on the other side?
Well, basically, at 5 years, we have only clinical data available for both studies. This is important to note. So we are not talking about patency. We are talking about freedom from reintervention. That means freedom from TLR. And basically, in the randomized controlled study, this freedom from reintervention was about 75%, whereas in the IN.PACT Global study, we are close to 7%. So the absolute difference is about 5%. But you already mentioned the randomized controlled study was a very selective study with mean lesion lengths of about 8 centimeters. In the IN.PACT Global study, we are dealing with a mean lesion length of more than 12 centimeters, and we have lesion lengths up to 35 centimeters enrolled. And besides long calcified lesions and instant restenotic lesions, also popliteal lesions. So this is a complete different kind of lesion subsets that had been enrolled into IN.PACT Global. So what does it mean if in a highly selected patient cohort, as in the randomized controlled trial, and in this global study, which is a kind of all-comers study, the outcome was very comparable. That means basically that the device which was tested within both studies, the IN.PACT Admiral balloon, performs well not only in standard lesions, that means task A and B lesions, which had been enrolled into the randomized study, but performs very similar also in complex lesions, in task C and D lesions, in instant restenotic lesions, in popliteal lesions. So overall, this gives confidence that this kind of drug-coated balloon is very efficient, regardless what kind of lesion we are treating. In particular, lesion length has only a mild impact on the overall outcome.
Thank you, Thomas. And I think that is really important to see that there's hardly any difference between the two groups, and I think this is related to the unique formulation of a high dose of paclitaxel combined with urea, and also the mechanism of action of this specific balloon. When I see all these data coming out, this really guides me in my choices in my personal practice. Can you tell, in your experience, what you would recommend to people that want to use drug-eluting balloon technology for treatment of their patients, and how you implement the data that was obtained with the IN.PACT SFA and the IN.PACT Global study in your own practice? First, back to you, Gunnar.
Yeah, thank you very much. So I think right now, given the data, there is almost no room anymore for a therapy with no prevention of restenosis with local drug delivery. So our patients, which we treat here, are all treated with means for prevention of restenosis. So if I just go in and have a very easy lesion, I treat this lesion with a drug-coated balloon, mainly in IN.PACT DCB first. So if I have a very complex lesion, a total occlusion, I predilate with a somewhat undersized balloon. If it looks quite good, I go in with the IN.PACT DCB and treat the lesion. And if there are rest stenosis or rest dissections, I even go in with the second balloon and do a long-term PTA. And if there are residual stenosis in some areas, I might place a stent in addition. So that's the main workflow which we do here at our institution. In some patients where there's really a hard calcium load, there might be also vessel prep mandatory, but most of the patients can be treated with these tools.
Thank you, Gunnar. And the same question for you, Thomas.
Well, basically, we have to talk about the ugly safety discussion before I can tell you what we are doing. Basically, we are offering every patient treatment with drug-coated devices, and in particular with drug-coated balloons. Why I'm talking about that? Well, we have still the warning effective of all the agencies in the USA. It's the FDA in Germany. It's BfArM, and these warnings are telling us that we should reserve drug-coated devices for lesions that are at higher risk for developing restenosis. So, but if you look into the data, what does that mean? Even in IN.PACT SFA, in the randomized study, we had a highly significant benefit of using drug-coated balloons over plain balloon. So that means even the simple lesions, task A and B lesions, if they are not treated with a drug-coated balloon, they are at risk for developing restenosis, clearly shown by those randomized data. And this is for me the rationale to offer my patients drug-coated balloon angioplasty where indicated in all patients. Regarding, again, the safety issue from IN.PACT Global, we know that we have a 5-year mortality in a complex, not only lesion patient population, but also patient population based on their baseline characteristics. They have a high proportion of diabetes. There was even, let's say, a cohort which was a protocol deviation with CLI of about 15% of the entire patient population. And we had an overall mortality rate of 19.5% at 5 years. And what does that mean? If we compare those data with epidemiological data from Austria or from England, a patient population which did not receive any revascularization suffering from claudication had a mortality if they had been non-diabetics of 38% in Austria and about 25% in England. So that means with 19.5% mortality in this patient cohort of IN.PACT Global, we are far below what you can expect for a similar patient population which is treated conservatively. So in my opinion, the safety issue regarding mortality is no real issue.
Thank you very much, Thomas. I think that was very important that you brought up the safety issue, and it's good to hear that that doesn't influence you anymore in your choices, in your practice, whether to use drug-eluting technology or not. I thank you both for your contribution. We have discussed the IN.PACT Global trial, and we have seen that there's actually a very consistent outcome in this study as compared to the IN.PACT SFA trials, despite the fact that much more complex lesions were treated in the IN.PACT Global registry, CTOs, in-century stenosis, very long lesions, and this indicates that the product that was used in both of these trials, the IN.PACT Admiral balloon, is a very efficient balloon in treating patients with peripheral arterial disease in the SFA and in the popliteal artery. I think it is important also to know that the safety discussion is probably something that we need to forget, and that there should be a differentiated approach in various types of lesions, as Professor Tepe has mentioned. Go directly for DCB in simple lesions, do proper vessel preparation in the more complex lesions, but in the end, you'll get a good result using the proper balloon. I want to thank you both once more for your time and your valuable contribution to this. And with that, I want to say goodbye to everybody and hope to see you all very soon live again.